So I'm going to switch gears a little bit and talk about late complications after LVAD placement. Actually, not complications, but everyday management of LVAD patients. And so you've heard some of these things from Dr. Eisen. You've heard from our previous speaker how, even though he said he's not an Avenger, you can save lives with LVAD placement. But we have to remember that the care of these patients is actually also complicated. So some of the questions I want to answer for you while we're here. The first question is, once a person has had a successful VAD implantation, do they still go on to develop recurrent heart failure symptoms or other cardiovascular symptoms? So they've had a successful surgery, they're at home, they recovered, can they still develop heart failure? If so, can these heart failure symptoms be ameliorated by adjusting LVAD speeds? Do we still need to use heart failure medications in these people in the ambulatory setting? And then finally, what are the best options to evaluate your patient's symptoms, and what technologies or medical strategies do we have to treat these people? So for durable VADs, this is just a wrap up of what you heard before in terms of durable MCS. So as you've heard, we're no longer using pulsatile pumps. Durable VADs now mean continuous flow pumps. And the shift in continuous flow pumps, as you also heard, is now going from axillary pumps to centrifugal flow pumps. And so what that means to you is that from HeartMate 2 to HeartWare and HeartMate 3 therapies. Destination therapy, as you heard, is meant for lifelong support. And the median survival for destination VADs is now approaching 5 years. So if you remember from the first slide from Dr. Eisen on rematch, at 1 year, only 50% of the patients were alive, and the best that pump did was at 2 years, only 25% of the patients were alive. So here are the currently approved continuous flow pumps. HeartMate 2 is the axillary flow pump, and the other two are centrifugal pumps. And basically all that means is it's the way the blood is propelled through the pump. Axillary flow pumps are linear. Centrifugal pumps just means it spins through. So this is from the recent IMAX database, which is an international database of VAD outcomes. And what's interesting is that the green line are patients who are being implanted for the indication of destination therapy or lifelong therapy. That's now almost half of all VAD implants are going in now for destination and not for bridge to transplant. If we look at survival for continuous flow pumps, this is both for any indication, you'll see that at 5 years, the survival is about 46%. So this is dramatically different from where we came from with the pulsatile pump days. In terms of indication and survival, patients who are bridged for transplant have a much better survival than patients who are destination therapy. But as we saw from the previous slide, destination therapy's come a long way from the rematch time. So though the survival rate for VAD therapy is superior to medical management for end-stage heart failure, and our technology, clinical expertise, and the durability of the pumps have improved, we still have a high number of adverse events which lead to hospitalization and eventually death. And most of these causes are actually related to cardiovascular factors. So this slide is a recent slide which goes over the leading causes of death for patients who receive continuous flow LVADs. And the first column is overall, and the other columns are at first year and then after first year. And you'll see that the causes of death change the further out you get from surgery. But what has remained the same is that neurological events are still the leading cause of death. Multisystem organ failure, which to me means ongoing heart failure symptoms, withdrawal of support, and infection. So those are the top reasons, and that really hasn't changed over the whole lifespan of the patients with the LVAD. The other thing you'll notice from here as well is that rounding out the rest of the list are all cardiovascular causes of death. So let's just look at hospitalization, and you'll see that in terms of freedom from hospitalization in the first year, it's really only 20%. So 80% of the patients are rehospitalized sometime the first year after their LVAD is implanted. And this compares axial pumps or centrifugal pumps, and it's not a head-to-head of HeartMate 2 to HeartMate 3, so it's HeartMate 3 and HeartWare versus HeartMate 2. And if you look at other complications such as stroke and GI bleed, you'll also see, and this actually shows both sets of pumps, but it's not significant at this point because they have too few numbers for the for the HeartMate 3 pumps. It's significant for all centrifugal pumps that we can't break out HeartMate 3 versus Heartwear or axial pumps. But you'll see that the freedom from stroke at 1 year is in the 90s, so that's pretty good. But when you get out here to 5 years, freedom from stroke is only 60%. So it's a pretty high rate. If you look at freedom from GI bleed by pump type, it's also 50 or 60% depending on what pump you're talking about. So for patients who have an indication of DT for their VAD implantation, you see that further out from surgery, stroke and GI bleeds are still occurring. So my question is, with these significant problems with LVADs, is there anything we can do to ameliorate the symptoms of heart failure? And in terms of heart failure, is it all just doing manipulations with the pump, like ramping up the speed, which seems like the simplest thing to do, or do you still have to use heart failure medications to ameliorate these symptoms? So we'll skip that one. So as you've seen before, LVADs save lives, and this is data from the first 6 months after an LVAD goes in. You can see that the heart size actually shrinks before and after, and hemodynamics dramatically improve. So people feel pretty good once they leave with their LVAD. But what we have to keep in mind is that even with normal operating conditions of the VAD, so there's no complications at all with the pump itself, managing these patients and their symptoms require you to also understand what's happening in the native circulation. So everything that happens with pump efficiency has to do with the loading conditions of the pump. And so that's what I want to focus on now. So it's not just turning up the speed and getting a simple pump flow. You've got to also manipulate the patient in terms of loading conditions. So LVAD flow is limited by an increase in pump afterload. And this is evidenced by the pressure flow curves, which I'll show next. And in addition to that, the other factor that you really have to control in these patients is their blood pressure, because that ties in directly to the number of neurologic complications that we see. The other thing, as far as preload, the LV must have an adequate preload in order for the pump to fill. So in other words, your pump can be spinning perfectly fine, but if the LV is not full, you're going to have a low effective cardiac output in patients who have symptoms of heart failure. So LV filling is actually controlled by really mostly the PVR and right heart function. So when you're trying to use medications, those are the two things that you're really going to manipulate in terms of LV filling. What's the patient's PVR? What's the RV function? And then finally, what's their overall volume status in terms of LV filling? So this is just to show you the physiology of a LVAD as compared to a native heart. And so what we find here is that LVADs are 3 to 4 times more sensitive to afterload or blood pressure. So they're very sensitive to afterload in terms of how much flow you're going to get through your LVAD. In terms of sensitivity, they're about a third as sensitive as the normal heart in terms of preload. So this is the pressure flow relationship that we were talking about before, and it really shows how much flow you get at a given speed related to the pump differential. So remember, flow across the pump is related to the pump differential, which in this case is the LVEDP versus the SVR. So whatever the difference between that will dictate how much flow you get through a pump at a given speed. So you haven't changed the speed, but if you change the pressure across the pump, your flow can be anywhere from 1 to 7. So that's the critical part in terms of what you can do with medical management. We can manipulate this part with drugs in terms of dealing with the SVR and making sure the LV loading conditions are normal. So you get this happens at both lower speeds and higher speeds. But the key thing to see here is that your pump flow is very sensitive to what the SVR is. This is just another way of showing that for axial pumps and also centrifugal pumps, the operation or the response is actually the same. So your flows, this shows just one cardiac cycle diastole and systole, and the pump differential here. So even within one cardiac cycle, you'll see a change in flow based on what the LV is doing in terms of contraction. So during systole, the pump differential is lower. Because the LVEDP is lower, you get more flow across. I'm sorry, higher, you get more flow across. So in terms of the RV, so the LV support Post-surgery, let me go back a little bit. Post-surgery, when you initially unload the LV, what we have to remember is at that time, you don't actually unload the RV at the same time. So that's something peculiar to LVAD. So even though LV unloading happens immediately, you actually fill the RV, increase the preload. And so for people with marginal function on the right side, they can develop acute RV failure. So that's why in the previous case, they talked about putting in a RVAD before they even got out of the operating room, because with the LVAD going in, you now load a weaker RV, and it may fail. So just to show you this pictorially, once this LV is decompressed immediately when the pump goes in, you send more blood flow to the right side, and if you have a compromised right ventricle to begin with, it will fail. And that leads to a vicious cycle. If the RV fails, then your LV preload is low, your cardiac output is low, and it just gets worse and worse and worse. And there's no really good way to deal with this medically, such as with inotropes, so that's why an RVAD is critical in this situation. And that's something unique to VADs. You immediately decompress the LV, and now all of a sudden your RV starts to fail. This slide is more important in terms of understanding how to care for LVAD patients later on. So we have to remember that really the name of the game for LV filling is to make sure that your RV is able to deliver blood flow. And so that's where RV function and actually PVR become very important for patients with LVAD. So if you have a patient who has significant lung disease, for instance, and a high PVR unrelated to cardiac reasons, they're probably not going to do very well with LV filling for the reason of a high PVR. If a patient has gone on to develop RV failure, you're also not going to get LV filling because of delivery to the left side. So now we'll get to the physiology of patients who have LVADs in place. So we saw a picture earlier, a nice video of a guy who was some sort of athlete, and he got a totally implantable VAD, and he was swimming. So the beauty of that is that he was in water and everything was enclosed, but if you really took a good look at him, he didn't seem to be vigorous. So patients who get LVADs in, even though their resting hemodynamics are fine, end organ function is improved, you'll notice that a lot of these patients still have exercise intolerance. And so this is an interesting hemodynamic study that was done with a Canadian group. They just looked at 11 LVAD patients and performed exercise hemodynamics on them. So here is the control group. And what they had, the pre-exercise group, control group. These are the patients who, there were 11 of them, who they divided up into people who could actually do exercise versus those who prematurely stopped on the treadmill. So these were all stable outpatients who said they really didn't have any symptoms, and they decided to enroll in this study to check exercise hemodynamics. And of the two groups, those people who could do light to moderate exercise versus those who could not, if you look at the resting hemodynamics, they look pretty similar. So they have SVO2s in the 60s, the pump flow is about the same, and at rest, they look fine. Those who completed versus those who terminated. But when you go over to light exercise, you find that 5 people had to stop very soon after they were on the treadmill. And what you see with this is that the SVO2 dropped dramatically in these patients when they started to exercise. At the same time, pulmonary pressure started to rise as well, and the wedge pressure. So these are clinically stable outpatient VADs who are getting exercise hemodynamics, and you see that for both groups, the hemodynamics go the wrong way when they get on the treadmill. For those who could continue on to the moderate exercise part of this, you see here that the PA pressures have dramatically risen. And those people in this group who had to stop early had SVO2s down to about 28%, high PA pressures, high wedge pressure. So this was kind of interesting just to see how, most people when they come to the office, they feel fine, or they tell you they feel fine. But if you really push them and say, okay, well, let's see if you can walk 3 or 4 minutes on the exercise, for an exercise test, it's interesting to see what happens with their hemodynamics, even though everything at rest looks normal. And these are just lactate levels with people who had to stop early. The lactate levels went up a lot more than those who were able to complete the moderate exercise part of this protocol. So the first question, the immediate thing we run to is, well, can we just turn up the speed, give people a higher flows, and resolve their exercise intolerance? So in terms of looking at LVAD physiology with changes in speed, that's called ramp studies, where they go up incrementally in the speed and check your hemodynamics. You find that as the speed increases on the pump, as you turn up the RPMs, the pulmonary artery saturation goes up. Here, also the cardiac output, even though it's not as dramatic as a PA-SAT, cardiac outputs also go up. And this is shown for the HVAD and the HeartMate 2, so centrifugal versus axial. So these numbers look good. As you increase the speed of the pump, your output improves, your fit cardiac output improves. You can also look at other parameters like the wedge pressure. That also drops for both sorts of pumps. CVP goes down. And here you don't see as dramatic of improvement in the, change in the CVP, so that's actually interesting. So even though they're turning up the speed and the left-sided filling pressures are decreasing, your CVP is maintained. And I guess in a way that's actually good, because you don't want to see a situation where the CVP increases because you're delivering more flow to the right side. That's sort of the situation you see immediately post-op. And at the same time, you don't want to see the CVP drop, because that's also our RV preload. So with speed changes or ramp changes, the CVP remains stable. The other thing that's very important about this slide, I guess I should show here, is that these people are, again, stable outpatients who are willing to join a study where the ramps speeds are increased. So they're all stable. And what the authors saw here was that 40% of them, before they even got started, had very abnormal hemodynamics. So again, with just medical management and using echo, they had people, when they actually checked their hemodynamics, which were very deranged. And it was about 40% of these people. So from that, it looks like, you know what, if we just turn up the speed, we're going to get better hemodynamics, and people should do better with LVADs. Well, this is a meta-analysis which was, I guess, published in 2018, and they were able to go through and look for studies who had exercise hemodynamics in VAD patients or VO2s. And they came up with 11 studies that met this criteria. And I'll just show the VO2 data here. Out of this 11, it was pretty much equivocal whether or not changes in speed actually, with ramp studies actually improved exercise tolerance. So if you'll see here in 4 of these cases, there was no improvement. And for those that did, it was very small, 7% or 23%. So from this analysis, it seems that maybe just changing the speed is not going to be the magic bullet to managing these patients who have exercise intolerance. So the next set of studies I'll go over, or sort of the conclusion that we have from this, is that in a cohort of stable patients, and that's what I thought was really interesting, who came into the office and agreed to have a right heart cath, you found that anywhere from 30 to 40% of them had abnormal hemodynamics. And then in terms of whether pump changes can actually improve the exercise tolerance, the jury's still out. So what about blood pressure management and continuous flow pumps? And this is the one that, taking care of VAD patients, we sort of knew it was a big issue, especially for patients when you had the pulsatile pumps, the blood pressures would be very high, 180s, 170s when those pumps went in. But when you introduce the continuous flow pumps, the question becomes, well, what blood pressure am I following? What is the blood pressure? Do I care about the map, the systolic? What's the story here? And so those answers have finally been answered, and I'll show you some of the most recent studies which pretty much seal the deal as to what we need to do with blood pressure management. So this just shows a very nice study. It looks at the comparison using Doppler blood pressures to mean and systolic blood pressures. And so, as would be intuitive, it really depends on whether or not the patient has a pulse when you check their Doppler blood pressure. So on the top, these are the patients who have pulsatility when you check their pulse and you do a Doppler blood pressure, and you see that there's really no correlation between what the Doppler's getting and the map. What actually does correlate is the systolic blood pressure. So if they have a pulse and you use a Doppler reading for blood pressure, what you're really checking is the systolic blood pressure. That's what correlates. When you go to people who do not have a pulse and you check their Doppler pressures, it does correlate with the MAP, and it also correlates with the systolic blood pressure. So that's the interesting phenomena about continuous flow. As you lose pulsatility, well, I'll show you here. As you lose pulsatility, the MAP and the systolic blood pressures become very close to one another. So that's what the point of is looking to see if you have a pulse in your patient. So if you were to take a Doppler reading, you need to know if what you're actually checking is a systolic pressure or you're really down here at the mean pressure. And that becomes critical when you think about targets for blood pressure control. And so what they came up with as an algorithm for how you interpret Doppler blood pressures, it really depends on the presence of a pulse. This is from the HVAD studies where they looked at neurologic complications and blood pressures. And what they found is if you're very serious about keeping the blood pressure less than 90, the mean arterial blood pressure less than 90. So what this was is that, sorry, I'll go here, patients who, with every clinic visit, never had a mean arterial blood pressure of 90 millimeters of mercury, they had a stroke reduction risk of 61%. So that was for hemorrhagic as well as for patients with ischemic. So controlling the blood pressure in this particular cohort was very important. And you remember when they were doing the HVAD trials, everyone was concerned about the higher stroke rate. So they went back and tightened up their protocol to aim for a MAP blood pressure of less than 90, and they saw a significant reduction in strokes. This is a more recent study that just came out I guess 2 months ago, and they looked at, in this study, this was also the HeartMate 2, they wanted to see what the effect of blood pressure management is on stroke as well as pump thrombosis. And so when you use mean arterial blood pressure as your point, you'll see that the composite for a low MAP, intermediate MAP, and high MAP, you'll see a tremendous difference between the stroke rate and the pump thrombosis rate. And so they also looked in this at also systolic blood pressures and were able to show the same thing, that you have improved or fewer complications for the systolic blood pressure being low as well. So if you have a patient with a pulse, you'll look at this. If you have a patient who doesn't have a pulse when you're checking blood pressures, this is more of the numbers that you would use. What you'll notice here also is that for them, in their 3 strata, that a low blood pressure is actually less than 80. So that's less than what you saw with the HVAD data. So they're shooting for a mean arterial blood pressure of less than 80. And they saw improved outcomes. So when they went with the 90 blood pressure, MAP blood pressure, which is what they use in Endurance, they also saw that this was a lot better than patients who had high, but 80 was actually better. So in practice, after seeing this, it looks like we should be shooting for a mean arterial pressure of 80 or less to decrease complications. And this just shows, the same thing that I just to show you pictorially, how much better the patients whose mean arterial blood pressure is 80 do compared to other patients. Okay, so to sort of wrap up what you want to do with blood pressure, so from your medication standpoint, even though the current recommendations say less than 90, it looks like you get an additional benefit if you drop down to 80. So to answer the question of should we be using medications in continuous flow LVADs, definitely, because we're really focusing on in the clinic on what their MAP or their mean arterial blood pressure is. Then what about aortic insufficiency? So this one is a very difficult one to answer. So in terms of patients who have aortic insufficiency with VADs, remember that it's continuous AI. It's not only diastolic in nature. So when you look at the normal heart without an LVAD, we say, well, you just do afterload reduction, and that will improve things. The other thing you can do in a VAD, though, is a speed change. Is that going to help you in terms of decreasing the amount of AI? So that's what they looked at in this particular study. What happened to hemodynamics and echo when they changed the speed in patients who have VAD patients who have aortic insufficiency. So here you see the baseline hemodynamics in these people, which the resting hemodynamics were okay, but you know that a lot of these patients have exercise intolerance. So even though these resting hemodynamics look pretty good, we know that in practice, and this is for the patients who have AI, in practice a lot of them are limited in their exercise tolerance. So this slide depicts what happens to your AI when they change the speeds. So in this one, this is for patients who have aortic insufficiency, and you can see that when they ramped up the speed or turned up the speed of RPMs on the LVAD, that the cardiac index improved, the wedge pressures came down, and the CVPs came down as well. We look for people with no AI. You also see the same thing. So, normal physiology, that the cardiac output improves, the wedge comes down, the CVP is flat. So that all seems good, just increasing the speed in somebody with AI. But the bad side is what happened to the amount of AI that they had when you looked at the echo. So if you look at the speed change, a lot of these people's AI were characterized as mild, or mild to moderate, or moderate. And the severes are moderate to severe are not much, but when they turned up the speed and ramped up the speed, you can see that the amount of severe AI on echo actually increased. So even though the hemodynamics looked better, on echo, it looked like that amount of AI actually increased. And for people who did not have AI at all before this thing started, you'll see that the amount of moderate to severe AI that developed, and I don't know why, this should have all been gray. I'm not sure why some of these people, non-AI group, had AI on here, but you can see that the proportion of people who developed moderate to severe AI increased when they changed the speed. So that brings up a interesting point. Even though at one set time during the study, you saw hemodynamics improve when they turned up the speed, you also see on echo that the amount of AI has increased. And so you wonder what that really means in terms of exercise tolerance and what's going to happen with these patients. The other thing about increasing the AI and having more flow through the valve is perhaps you'll do more damage to the aortic valve, making it even more stenotic and more AI over time. So it's not clear to me how the resting hemodynamics are going to translate into improved exercise tolerance when you can see on echo that you're actually causing more aortic insufficiency. So I can go through here. What about GI bleeding? So my first thing is always, well, can we change the speed? Is there something we can do here? You heard from Dr. Eisen that most of the bleeding from LVAD patients actually comes from the development of AVMs. So the thought was, well, we'll actually decrease the speed in these patients, give them some time where they're in diastole, where the flow maybe stops, and then hopefully the bleeding will stop sooner. So as opposed to continuous flow where you're continuously driving blood, or non-pulsatile flow where you're continuously driving blood through the circuit. So the thought was, let's just drop the speed and see if that helps us at all. And so this is an analysis that was done, I think this was the Mayo Clinic as well. And what they did was look at patients who had right heart caths for usual clinical indications. And then they went back through a chart review and saw how many GI bleeds these patients had vis-a-vis what their hemodynamics were earlier. And so they looked in terms of endpoints at what the right atrial pressure is, the CVP, and what the pulse pressure was, or the pulsatility from the LVAD. So in this case, they saw that patients who had a lower CVP had fewer GI bleeds, and they saw that patients who had a pulse pressure of greater than 35 had more GI bleeds. So that was an interesting finding for them. And so what they actually concluded is that freedom from a GI bleed is significantly greater if you have a low CVP, and also greater if you have more pulsatility. So that theory sort of worked out. If we just increase pulsatility, increase time where the flows are low during diastole, perhaps that would help with closing AVMs. The least favorable profile are those who had a negligible pulse pressure and an elevated CVP. And they found that there was really no difference between whether or not the pump was centrifugal or axial flow in this particular analysis. The other thing about this analysis is that they weren't looking at INRs at all. So they were assuming that patients all had, well-regulated INRs at the same institution. And so they conclude that maybe decreasing speeds would improve outcomes for patients who have had recurrent GI bleeds. So in terms of the next question, what is the best option for trying to evaluate these patients, since we know that physical exam is not always the best based on some of these resting hemodynamic studies that we've seen? And is there any role at all for hemodynamic ramp testing? So this is just another depiction of where stable outpatients had high wedges and high CVPs going into the study, which was a surprise to the investigators. In this protocol, what they decided to do is optimize patients one time, and then see how they do over time. So they enrolled, optimized hemodynamically. They enrolled 88 patients, and at baseline, half were not optimal and half were. So they went through and found the perfect speed that gave them a CVP of less than 12 and a wedge pressure of less than 12, and set them there, and then saw how they did over the following year. And again, what was interesting is that they were not able to optimize or achieve these hemodynamics with about 34 of the patients, about a third of the patients that they were looking at. And so what happened when they did this? So this is the one you just saw at baseline speed, where you had a lot of people who were already out of range. You were able to get 2/3 or 54 of them optimized, and the other ones you were not. They were either too low or too high. Too low is sort of interesting. But they were able to optimize about 2/3. And so what happened in terms of outcomes? So in terms of readmission rates, they saw that the patients who were optimized were less likely to get readmitted. And when you look at the causes for readmission, they were actually mixed, non-heart failure and heart failure related. But optimizing them by speed one time seemed to decrease their admission rates to the hospital, both for heart failure and for non-heart failure causes. So the next one is really sort of the study that everybody's waiting to see in terms of optimization. So this is the pilot portion of the Ramp It Up study. And this is done with HVADs. And what they wanted to do, again, is just now do a comparison between a control group and a group of patients who they decide to optimize using RAMP studies. And you can see all the usual outcomes that they're looking for. Okay, so in this trial study of RAMP testing, the first panel is quality of life. The patients who, and none of these really have any p-values on them because it's a pilot study, but they say that the hemodynamically optimized patients had a better quality of life. The 6-minute walk test didn't really change. That's interesting. And so in terms of exercise capacity. And it seems to be a signal that there are fewer GI bleeds in this case. I guess there were no strokes, they couldn't comment on that, and less heart failure. So hemodynamic option or optimization in this particular trial seemed to trend towards a better quality of life and fewer adverse events in patients who were optimized hemodynamically. And the main trial is actually underway now. So to answer your questions, after a patient has survived the surgery, successful bad implant, can they then go on and develop heart failure symptoms? And the answer is absolutely yes. So you can't just put it in, pick a speed, and call it a day. Can the heart failure symptoms be ameliorated by adjusting VAD speeds? Yes, they can. So either up for patients who have exercise intolerance or down for people who are having GI bleeds. In terms of the role of heart failure medications, yes. So what we really should be doing with our heart failure medications is help to optimize loading conditions in the LV by treating RV dysfunction, high PVRs, and making sure that patient's volume status is optimal. So in other words, not too dry, because that could be a problem for you as well. In terms of the best options to prevent this from happening, in other words, can we just optimize people up front and that's the answer? Well, that remains to be seen when we see the results of the Ramp It Up study. So to conclude for us today, continuous flow LVADs have increased survival, there's no question about it, in patients with end-stage heart failure. But there still happens to be a huge mortality, morbidity rate due to heart failure, GI bleeds, and strokes. And part of these conditions are certainly driven by hemodynamic factors, so things that we can hopefully manipulate. Optimizing patients requires a balance of pump programming and medical management to optimize blood pressure and loading conditions. At this time, the best combination isn't known, so you have to just play with it in each patient as they present to you on that day. In heart failure, the impact of changes in RPM on exercise quality is surprisingly mixed, so it's not a straight one-to-one, increase the speed and pump flow, and the patient will have a better exercise tolerance. We have seen in the Ramp It Up trial that there is in the pilot anyway, that there seems to be fewer readmissions if you optimize and an improved quality of life. For GI bleeding, it seems that patients with a high CVP and low pulsatility do worse. So that seems to, you wonder if you need to improve pulsatility in these patients. For AI, that's really a mixed bag for me. You can, in the short term, with increases in ramp speed, increase the flow across the pump and decrease some filling pressures. But what does that do long term if you increase the amount of AI that this patient has? Yeah, and I can't hammer enough again the blood pressure issue for these patients. And finally, I wonder if you can now have patients have a programmer which will automatically change speeds for you, or actually a rate detection, sort of like pacemakers. Maybe that's what we need to help improve exercise quality in these patients. And those studies are also underway. And I'll stop there. Samida.